it's my understanding that the primary tool I offer is presence. There's a story in my book when I was new in training. I'm called to the ICU in the middle of the night. It's a terrible, terrible, terrible death. The patient and his wife didn't even want a chaplain. It was her sister who called me, and the sister disappeared. And here I am in an ICU in the middle of the night. I've been calling myself a chaplain for about 1 month. What am I supposed to do? And as I sat there, I had the understanding that by my presence, I represent the fact, I remind us all that something spiritual is taking place, that it's not just a physical event. We are not just meat, right? No matter what your beliefs, you can have religion or not, something spiritual is taking place.
Renshin Bunce lived for 7 years at a Zen Buddhist monastery before she left to become a hospice chaplain. In her latest book, Love and Fear, Notes from a Hospice Chaplain, Renshin shares her realization that every death is different and there are no universal rules or easy answers in hospice care. She joins John and Scoop in this episode of the Plutopia podcast as we discuss life, death, and hospice care.
To the Plutopia podcast. Our guest today is Renshin Bunce, a hospice chaplain and Zen priest. She was priest ordained at San Francisco Zen Center in 2003 and received dharma transmission in the April of 2013. She's the author of Love and Fear, Stories from a Hospice Chaplain, the book we'll be discussing today. Hello, welcome to Plutopia.
Thank you so much. It's so nice to be with you.
And just to start out, I'd like to ask you about your decision to leave the monastery and how you became a chaplain.
It's a reasonable place to start, and I'm probably going to take one more step back, because when you say leave the monastery, what kind of person ends up in a monastery, right?
Oh, indeed.
Right. So I like to say I was fairly normal, suffering, using my credit cards to look like I was more successful than I was, following what seemed to be a fairly clear roadmap to pursue men and money, and then I'd be happy. So, yeah, I know. We laugh now. It seemed like a good idea at the time. The step behind that is that I got sober when I was 35, and by the time I got serious about my life, my resume was such a mess that the way I was pursuing men and money was by selling real estate in San Francisco. And if that's not a recipe for suffering. So, I mean, excuse me, I know Marcia has done, some people do well with selling real estate. I didn't.
She would agree with you, I think.
What I saw when I was out of the field was the setup is that you have to be competitive with your friends. And that, right, because you're all going for the same dollars. So somewhere in there, I'd begun meditating, and gradually, I began going on retreats, and gradually the meditation practice and what I was finding in long periods of meditation was more interesting than the worldly success I'd been pursuing. So I think I was somewhere in my 50s when I cashed out my IRA to pay off my credit card debt and moved to a Zen Buddhist monastery. I thought that doing that meant that San Francisco Zen Center would be my home forever. My psychological type is the abandoned child. I'm always looking for family. So I thought, oh, here's my family. And if I just do what they say, if I'm a good Zen student, then I'm set. They'll not only provide me a roof and 3 meals a day, but they'll love me. Well, maybe not so much. And John, with your encouragement, I wrote about that. And I compiled what I wrote online into an earlier book called Entering the Monastery, which is a simple record of me crying, running around the monastery and crying. It was fantastic. It achieved its purpose. Zen works, and big chunks of Zen work better than meditating for half an hour a week. The idea that Zen Center, that an institution would take care of me forever, was false. That was just something I made up. Zen Center is not at all interested in taking care of people. I understood partway through my residence there. I remained in residence for 7 years. And I understood partway through that any institution's primary goal will be its own survival. So maybe partly because of the kind of person I am, I'm demanding, I'm emotional. I think that the people who last long-term at an institute at San Francisco Zen Center are more quiet. Maybe even, I don't know, easier to get along with, less demanding, I don't know. But very few people settle in and spend their lives there. And I was not one of them. When it was clear it was time for me to leave, what was I going to do? I wasn't going to go back to selling real estate. And I thought, well, you've been well trained, you're a priest, you've taken this vow to be helpful, so really you can do anything. Go ahead, get a job at Starbucks, that's valid. But a friend suggested being a chaplain. She was also a priest, and she'd been a volunteer chaplain, and she'd found it rewarding. So I gave it a try. There's a really good local training. It's called the Buddhist Chaplaincy Training. A teacher called Gil Fronsdale. It comes out of his center. Yeah.
I'm very aware of Gil Fronsdale.
Great guy. He and Paul Haller and Jennifer Block got this together after 9/11. They saw a need for Buddhist chaplaincy. So that's a year-long program. It's you go once a month and you do volunteer work. So I started volunteering, and it worked. It was what I'd been looking for.
What's the certification you get? Is it like a Master of Divinity, or?
As the story goes, I did that part-time training. Then you do a 1-year hospital residency, and I went right into that. So often, if you're in a hospital and a person comes in your room and says, "Hi, I'm the chaplain," this is someone who's probably talked to 4 patients before in their life. This is a student. So I was that person, and the patients taught me how to do the work. So to come out of that, that's called CPE, Clinical Pastoral Education. As I tried to find a job and was unable to, I realized I was missing that one other piece, which is a Master's of Divinity. Isn't that great? Check it out, man. I'm a Master of Divinity.
That's great.
It's a Christian setup. Chaplaincy is a Christian idea. So students go to seminary, they become a Master of Divinity. They'll do maybe 1 3-month unit of CPE as a part of that. None of the institutions I was involved with had the authority to grant a degree like that, but the American, one of the granting organizations has an equivalency path for Buddhists. So I took 1 month and reverse engineered, I think it was 62 units of divine training, which included meditation, it included ritual, it included classes. So I have an MDiv equivalency. And the week I got the piece of paper granting me the equivalency was the week I finally got a job as a hospice chaplain.
Perfect timing.
Yeah, close. It was close.
So I'm thinking back to what you said a little bit earlier about how uh, the the monastery or the Zen training had achieved its purpose. You mean your purpose in going there, right?
Yes, because isn't it true? Isn't it true that the wonderful places we arrive in our lives are wonderful because we couldn't have imagined them. So I was going for comfort and security, but no, that's not what's interesting. And it's certainly not what the institution gave me. What I got, going for comfort and security, hoping to look fabulous in the big black robes swooping around a zendo, right? That'll do it. That got me onto the cushion. And that forced me to spend thousands. I was there for 7 years. How many hours of seated meditation, stuck with nothing but my own mind to look at and learn about? What
Or
is it?
sometimes in sesshin for long periods of time at a stretch, right?
Oh, every month there was a sesshin.
Yeah.
In a normal day, we sat 7 periods. And then sesshin would come along and we'd sit even more than that. We were in silence most of the time. We ate our meals in the zendo, still sitting cross-legged on our cushions in a ritual fashion. You couldn't get enough food, and who wanted it anyway, because it was all beans and tofu. But good vegetables, we got good vegetables. It was, what do we want from spiritual training, right? Isn't that an interesting question? Honey,
I
it's
always think of
it's
Zen as
not
being,
comfort.
I always think of Zen as being sort of not exactly about purpose, or at least not having a gaining idea.
Right.
But you're not going to do it unless you have something driving you, right?
Yes, yes. You know, I'm a very stubborn person. I'm a very persistent person. Those qualities haven't helped me so much maybe in the what we could call the normal world, but those are very good qualities in a Zen student. Something has to keep you on that cushion. I had the great good fortune to find a wonderful teacher and had that connection. And that Myogen Steve Stuckey was his name. He died 7 years ago. We practiced together for 20 years. And to have a teacher, Steve gave me, he gave me Zen to the extent that I was able to receive it. He gave me an experience of unconditional love, which is so, so rare. So one time, how does this go? Steve had a story. He started in Zen practice with Richard Baker at San Francisco Zen Center. And one time they'd had some frustrating experience. And Steve said to Richard Baker, "Why Zen?" And Richard Baker's answer was, "Because Zen produced Suzuki Roshi." So my answer is, because Zen produced Steve Stuckey.
And that's the lineage. Steve
That's
Stuckey is
lineage.
in the lineage of Suzuki Roshi,
It goes Suzuki
and many
Roshi,
others.
Mel
Yeah.
Weitzman, Steve Stuckey, me. Yeah, yeah. And he was diagnosed with pancreatic cancer. It was quite startling. A few months after he gave me Dharma transmission, and he died within 3 months. So I just slipped in under the wire.
Yeah, it's a terrible loss.
Terrible. Well, yes and no, John. Yes and no, because in a year, perhaps the year after his death, I said to him, you didn't have to go to this much trouble to teach me about the porous nature, the permeability between life and death. And you didn't have to go to this much trouble to teach me about grief. But now in my work, I'm able to work with people who are in deep grief because I know that state. So terrible loss and more.
So in getting to our discussion about hospice,
Yeah,
I think a lot of people don't have a clear idea how hospice works. So could you just kind of give us an overview, and
absolutely.
especially about how the role of chaplain works with the other roles in delivering care in a hospice setting?
Good. Well, now I hesitate because which hospice am I going to talk about? Am I going to talk about the hospice practice that I write about in the book and that I was a part of for 10 years? It's changed so much during the time of COVID. But let's say in the before times, a person comes onto hospice when their doctor signs a piece of paper saying they have a life-threatening illness and it looks like they're going to have 6 months or less to live. So that triggers hospice. Hospice is a Medicare benefit. When people come on hospice, the heavens open and stuff rains down on them. Wheelchairs, hospital beds, medicine, and people.
And it's all to make them comfortable, correct?
The purpose of hospice is comfort. The one thing that the patient and their family members have to give up when they enter hospice is treatment for cure. They have to agree it's from now on, from this point out, it's all comfort. There can be chemo and radiation, for instance, that are designed for comfort and Medicare, but this is all Medicare rules. So there are a lot of different hospice companies all across the country who contract with Medicare. We offer services, Medicare reimburses for them in a complicated way that I don't really understand and don't need to.
When you say that the cure is not a goal, have you experienced situations where people have changed, our families, people have changed their mind, and how is that dealt with?
People do change their minds and then they can revoke hospice and we wish them well. We go through recertification periods. We have to make sure that the patient is still hospice appropriate. I think the first recert period is 3 months out, and then we review the case every 2 months. If the patient doesn't show decline, then we discharge them. It's called a discharge for extended prognosis. Oops, looks like it's more than 6 months. We'll have people on our service for years. When I first started, again, it was 10 years ago, things were looser and it was not unusual for someone to stay on our service for years. Then Medicare began coming in, taking money back and putting small nonprofits out of business. So I've been in the field during the time when the emphasis on money, charting, eligibility, when all of that really is almost the tail that's wagging the dog. We have to create charts, electronic charts, that someone from Medicare can look at and they can see decline. So nobody knows how long anyone has to live. How many, if I had a nickel for every time I've said that, everyone's taking their best guess.
When the changes in Medicare funding occurred, did those changes equate to a change in the political control of Medicare? Who was in charge?
Who was president 10 years ago? As I understand it, it's not that the regulations changed. We all knew the rules all along. But yes, there was. So if I started 10 years ago.
Oh, that would have been Obama, actually.
And the change of the Republicans taking control of Congress.
It didn't, I don't know. But it was suddenly, if you want, a famous case was Hospice of San Diego, which was a nonprofit, well-loved, doing great work, and they were put out of business. And what has happened since then, there are, it's big business. There are for-profits. The first hospice I worked for was a big, can you believe it, for-profit hospice. So they have been buying up the little community nonprofits. Everything in healthcare comes back to money, and it's really frustrating. And a part of my book is my shock when I finally got a job and I realized that that's what the landscape was. I thought it was going to be all kumbaya all of the time, and it was just the contrary.
Yeah, from my own exposure to hospice, I have become clear that it's quite a bit about moving money through. Like, money comes from Medicare and moves through the hospice, and that is often the focus. And one of the problems with that focus is that there's an incentive to understaff, in order to increase profitability. And I've actually seen cases where it seemed to be that they were trying to operate with too little staff because of the money concern, because of the profitability concern.
I'm going to argue, I have not experienced that. And I've worked for 3 hospices, and there's always a challenge to find enough people. The place where we see the understaffing, shouldn't use that phrase. The phrase where we see minimal staffing, perhaps in an aim for profit, is in the nursing homes.
That's been evident here in Texas, where many of the COVID deaths and infections have been in the nursing homes.
Oh, just
and,
nursing homes.
It all revolves around money. How many people they have for taking care of these people.
And again, I'm going to argue a little bit, because locally, there's one place that was hit really hard is one of the finest assisted living facilities I know. Wonderful, caring people, always plenty of staff. It's all memory care. It's large. It's beautiful. I've had many patients there. And COVID got in the early days, before we understood anything. COVID got into that facility, and I forget what the number of people is who died, but huge number of people died. But there was no understaffing. It never had a feeling of trying to wring dollars out of the sky. So that incident showed me how random and how insidious COVID can be. And in a nursing home where, I have lots of experience, and talk about it in the book, where I'm visiting a patient and there's someone in the hall, help, help, help. And I go out and look, there's a little old lady in the wheelchair, help, help. And there's someone standing by the Medicart right near her. And I say, excuse me, that little old lady seems to need help. And the staff member says, oh, she always does that. That's different. That's where we don't want to be. And certainly the understaffing, I'm sure, has contributed to the level of deaths from COVID in nursing homes. But again, I offer the example of, once it gets in, no matter what, it's brutal.
And part of it's not having the right equipment. I know that I know a nurse who was exposed because even though she was wearing a mask and she was taking all the precautions, she didn't have a shield over her eyes. And a COVID patient coughed on her and it came in through her eyes.
Yeah. So
that's important too.
We were talking a lot about, were we going to take COVID patients? as soon as, I mean, do we want to go into COVID and how it's been?
It's definitely on the agenda. It was a little farther down, but let's go for it.
So I often watch Rachel Maddow, and Don McNeil, the science reporter for the New York Times, was on, it must have been early March, and he talked about what was coming. And I got really scared. And I know that the last time I went into a facility was March 11th. And I'll backtrack a little to say that in hospice, we visit patients in their home, and that home may be a nursing home, an assisted living facility, a private residence. So I was starting to feel uneasy going in these big nursing homes, hearing what was coming and seeing no precautions at all. So I used my sick leave and stayed home to see what was going to come. My company stopped doing in-person visits, I think 10 days after that, which is the time that here in the Bay Area, the Bay Area really slammed the lid on this early. So it was stay home. Since I think now March 24th, Medicare standards used to be that nurses had to visit at least once a week. If a patient started to decline, needed more care, versus nurses would visit more frequently. Medicare changed it first to a nurse visit, I think every 2 weeks, and now it's an in-person visit, and that can mean standing in the doorway, looking across a room every 3 weeks. All chaplains and social workers' work became over the telephone. Nurses do phone visits on the weeks when they're not doing in-person visits. What I offer as a chaplain, now we're getting to a topic.
Actually, that was going to be my next question, which
I
was
read your mind.
why is it important to include?
Decades.
Why is it important to include a chaplain on the care team?
So it's well, gosh, that is such a vast question. And so to finish the train that I had started, it's my understanding that the primary tool I offer is presence. There's a story in my book when I was new in training. I'm called to the ICU in the middle of the night. It's a terrible, terrible, terrible death. The patient and his wife didn't even want a chaplain. It was her sister who called me, and the sister disappeared. And here I am in an ICU in the middle of the night. I've been calling myself a chaplain for about 1 month. What am I supposed to do? And as I sat there, I had the understanding that by my presence, I represent the fact, I remind us all that something spiritual is taking place, that it's not just a physical event. We are not just meat, right? No matter what your beliefs, you can have religion or not, something spiritual is taking place. I don't know why hospice has chaplains, and John, frankly, I've come to understand that I'm a fairly unusual chaplain, and it goes back to my being demanding. When I was in training, I saw if I did something, said something with one patient and it worked, I would just run right to the next patient and do the same thing. And I thought, well, Zen, you can't do that. You have to arrive at the moment fresh. You have to meet the moment. I have to now have the courage, this takes a lot of courage, to let the patient tell me, let me know. And this is most usually not through words because they don't know. But what do they need? What's the need? There's a lot of crossover between volunteers, social workers, and chaplains. And so we have the handy group of words that says a chaplain is specifically trained to to see where the cracks are, to see where the existential terror is. Everyone's afraid of dying. I actually, it's my goal to be the person who can talk to them about that. Not, right, Zen again, not talk them out of it, but talk to them about it. So I'm having the same chitty-chatty conversation with a new admission as everyone else does, but I can see those pieces go by. Also, in this famous electronic charting, fortunately, one of the symptoms of a spiritual need is loneliness. So I've always looked for the lonely people. I've looked for the little old ladies who have no family, who are in a bed in a very basic skilled nursing facility, who have no visitors. That is what that has always been, I would say, my first priority. I love smart people who want to talk about life and death, but I feel for those little old ladies. I'm afraid of becoming one. I'm trying to pay it forward. But that's exactly the kind of visit I can't do anymore because I'm not going into those facilities. But loneliness expresses in many ways. And I hope that chaplains are particularly good at addressing that.
Buddhism is more of a non-theistic tradition, but I know that you showing up as a chaplain, some people will have the expectation that you're coming from a Christian background. How do you sort of deal with that expectation when it's there?
It's tricky. I don't want to disqualify myself. If someone, when we're first meeting, says, well, what are you? There's a reason for that question. If it's to disqualify me, I used to kind of beat around the bush. And again, there's a group of words. Oh, well, everything that I do is non-denominational. The only thing that matters is your belief, not mine. And sometimes that's sufficient. An evangelical Christian, someone who believes if you have not accepted Christ as your Savior, those are the only people they want to hang with. They won't want a Buddhist. And one of the important stories in the book is an early case where I circumvented the family's request. I finally managed to add a Christian who could visit the patient, but that was a case of loneliness. That was, to me, a mistake where the patient, a fairly young man with dementia, early onset dementia, had been put into a facility, and his wife had left town. And that looked so lonely, and I really wanted to visit him. So I did kind of talk tricky. I did evade the question as much as I could so I could visit that fellow. But, I'm in Northern California, and usually if I say I'm a Buddhist, the response I get is, oh, cool. Whatever people think Buddhism is, right? Oh, cool. Yeah, I like Buddhism.
So, do you ever have contact, when you're in facilities or were in facilities with the caregivers? Is that ever, and being one myself for the past 15 years for my wife, it has stresses and challenges. Have you ever had or tried to deal with some of their problems?
Oh, caregivers are very, very much a part of my work, absolutely. And, Scoop, I'd say more now than ever, because if we go back to the patient with dementia who's in a facility, my concern now over the phone is for the caregiver. Most of the facilities are not letting family members in. So here's an extra layer of stress. Not only is someone who you love in need of care, but you can't get to them. And some of the facilities will help family members FaceTime. But again, if we get to the SNFs that are so chronically understaffed, and SNF stands for a skilled nursing facility, they're so understaffed, the staff doesn't have time to do that. you add that on to the grief that we're all experiencing, the nationwide global grief of COVID, of losing our cherished way of life, as we all did one day all together. Caregivers always have been, certainly, I mean, anyone, co-workers, the checker at the grocery store. My vow as a priest is to be helpful. So in a way, finding this work, it took me a long time to find my work in this lifetime, but I have found it. And to be able to do something that meets my vow, that furthers my understanding of my vow as a Zen Buddhist priest, and get paid for it, is crazy. It's wonderful. And sure, I love my caregivers, and what terribly hard work that is.
You talk about in your book about ritual. How important is ritual in your spiritual work with the patients?
Not very, John. Not very. The only time it really comes in is when I do a memorial, a funeral. I have that crazy story in the book where I was asked to do an exorcism, and I did, and it worked. That was, I mean, again, crazy, and that's my job. That was wonderful. But ritual, a priest in the world, we get kind of removed from what you and I would think of as ritual, the beautiful robes in front of the altar, the bowing, the chanting. Not much room for that.
So they don't necessarily expect that from you.
No, I hope not. No. It used to be that my coworkers would get excited when a Buddhist came on service. Ren, we have a Buddhist. but there are so many. That's just like saying to a Presbyterian, we have a Christian. There are so many different flavors. So an American who's a Zen Buddhist, that's like gold. We have really interesting stuff to talk about, and we may perform ritual together. But my Buddhists are more likely to be Chinese or Japanese, and we're not performing ritual together. I will say that with my grief clients, I sneak in. I don't present it as Buddhist, but there are rituals that have helped me get through grief that I suggest to people, not as Buddhist, but just as something that helps.
Is there any particular case that was really pivotal for you, that really changed your thinking about the work?
Oh boy, so many. I pivot and pivot again and pivot again.
So you learn a lot from the patients that you work with.
Oh, it's the only way you learn. It's the only way you learn. You can't. You can't learn it from a book, and you can't even learn it from another person. A friend was talking about going out in a little sailboat on San Francisco Bay and learning to sail that way, by almost dying. And he said that was a mistake. He said he should have found some people who would teach him how to sail before he went out alone on San Francisco Bay. And I thought, it's different with my work. No one can teach you. And every chaplain I've met does it differently. We're all doing what we think is necessary.
Yeah, and every patient is going to be different just inherently, right?
And let's hope that we have enough self-awareness and, again, enough courage to recognize that. And I worked with this guy. he just all he did was sing Amazing Grace. He had shtick. He'd come up to a patient, he'd sing Amazing Grace, and he'd go to the next patient, and he'd sing Amazing Grace. So that was valid. That was a chaplain visit. That was his version of a chaplain visit. Another thing about me is I seem to have, I'm not only demanding but restless. I love variety. It's another reason that the work has suited me so well. Every day, believe me, every day is different. Every patient is different. So in the starting section of the book, when I was talking to patients in the hospital, when I was doing my residency, that was good. But when I was called out in the middle of the night to really dramatic situations that no one could have prepared me for, every one of those was pivotal, and every one of those contributed to showing me the possibilities in the work.
It sounds like there's no standard operating procedure in being a chaplain. There's no, I doubt if there are many useful guidebooks of this is what you do and this is what you do, because as you said, everyone is different. Has anyone ever approached you with that thing of, well, maybe you should write a guidebook of how do you do it?
I just did.
Well, well, yours is quite different. The usuals. This is step 1, 2, 3. This is exactly what you do, and don't deviate. I don't think you'd ever come up with that.
I'd say if you're not deviating, you're not trying hard enough. Scoop, I don't do well with textbooks. My mind just doesn't do well with, and I have books on, grief counseling and stuff like that. I can't read those books, but tell me a story and you have me. So in a way, that's what I tried to do with this book, is talk about how to do it, talk about what it is through stories.
Yeah, a very wonderful set of stories too.
Thank you. Thank you.
So you mentioned earlier that question, what good is Zen? The last chapter in your book is called What Good is Life? And you talk about your own diagnosis of cancer.
Yeah.
How has that changed you and your work? What impact has it had on your work?
It was what was it now, 6 months, 9 months? It was last fall that I was diagnosed with lymphoma. It's going to be a long time. And it turned out what I had was a little lymphoma. It was almost like it was my warning signal, my test case. The primary event was going through radiation, which was very, very hard on me. So I think it's going to be a long time before I understand all the ramifications of it. I do know the top layer is the understanding of what it is to be a patient in the modern American healthcare system. I have advanced directives. I've worked a lot with patients choosing the End of Life Option Act. I've thought about that. I've thought about the kind of death I want. So I was ready for these conversations with the oncologist. The question never came up. The question of what I might want, the only thing that the oncologist, and I liked her a lot. I had 2 of them. I liked this one. Was, okay, here's what we're going to do. And I'm sitting there in a paper gown saying, okay, let's do it. And once I was in the system, how completely powerless I was, and how there was no one who could help me understand what was going on. So yay, that deepened my determination to help patients and family members understand what the hell is going on, which medical people have neither the time nor the inclination to talk about. Oh, I wanted to find that person.
Yeah, I guess it's the idea of the empowered patient, which is something that I learned about a long time ago from a physician named Tom Ferguson, who wrote a book called E-Patients, and it was really about empowered patients. It was actually a white paper, and he worked with several healthcare professionals on it, but it was really about fixing that problem and creating a healthcare system where the patient can understand what's going on, and can leverage their own intelligence and can be kind of in the driver's seat of their own treatment. And it sounds like your experience wasn't quite like that.
No. I have a few little pictures up on the wall above my computer, and one of them, I was talking to one of the social workers, and I wrote down in the little book I had there, take back control, because you lose all control. So I'm the one who says, do you understand that since you're on hospice, that it means that the time you have left in this life is very short? Do you understand that you're feeling the way you feel because you have cancer? Cancer is living on your energy and you're becoming weaker. Do you understand that this trajectory is only going in one direction? I've worked with nurses who can talk about this. I've worked with doctors who can talk about this. I think it's the Zen training that makes me so willing to talk about this. And we just don't. And we live in a, 20th century America created the myth that we're apparently all going to live forever, and also that death is a failure. So I talk about that. I really normalize death. This is not a failure. People often reach a point where they stop eating and then stop drinking. And many times I have said to family members, you understand that people have been dying this way for thousands of years. You understand this is normal. I normalize death.
You said that your Zen training sort of helped you to understand this. What was it about the Zen training that made death more approachable, I guess? Is that the right word?
I think it's the part of Zen training where we're instructed not to turn away. Don't turn away. Look at it. Right? That is Zen. It. And that's what we're doing in those thousands of hours on the Zafu. Turning away until we have no alternative but to look straight at what's going on. And John, it all started, I'd say my hospice adventure started when I cared for my mother. And she was dying, and my mother had a very bad death. My mother died screaming. So I thought at that time, if we can understand what's happening, then we don't have to be so afraid. So I thought, I'd better learn more about death so I won't die screaming. And that's what I try to do for my patients too, just to help them understand what's happening.
Well, I want to thank you very much for joining us today.
I thank you for your questions. You are terrific at priming my pump, John.
Oh, thank you.
I've enjoyed this very, very much.
And
I want to mention again,
wisdom.
I want to mention again that the name of your book is Love and Fear.
Yep.
And that it's available on Amazon.
Yes, it is. Thank you so much.
And for those of you who are listening to this podcast and want to find a link to that, go to the Plutopia website. We'll have the link there.
Learn more about Renshin at renshinbunce.com. Her book, Love and Fear, Notes from a Hospice Chaplain, is available on Amazon. You can follow the Plutopia News Network at plutopia.io. On Facebook, go to @Plutopia News. On Twitter, it's @Plutopia. With John Lepkowski, I'm Scoop Sweeney. This is the Plutopia News Network, 20 minutes into the future.